Okay, good morning to everyone. So I'm going to briefly go through about the clinical signs and symptoms of spinal cord injury. So it is very important to assess this to come into a diagnosis, because when you get heaps and heaps of patients in an accident and emergency department, it's not always practical to image each and every spine. So we need it's not practical to image each and every spine. So we need to assess clinically and do the appropriate management. So symptoms and signs subsequently I'll go through under these subtopics. So when you talk about clinical features of spinal cord injury, never forget that commonly spinal injury is part of polytrauma. So please pay your attention to other life-threatening injuries. So when we talk about the clinical features, we always start with history or the symptoms. So as we all know, typically or most commonly these patients present following a significant trauma, maybe a fall, maybe road traffic accident, maybe assault, gunshot injury, whatever. In an exceptional scenario, you might get a patient found unconscious by the road or found unconscious somewhere else. But that's a less common scenario. So usually they will give a history that may point you to suspect either direct or an indirect spinal injury. And of course, a conscious patient will complain about pain, numbness, weakness, or other sphincter deficits like he or she can't pass urine or incontinent to urine or bowel or both. So when it comes to examination, a clinician need to elicit signs that could have occurred due to the impact itself or due to the bony ligamentous injuries or the vertebral injuries, which are usually associated with surrounding soft tissue injury, and the neurological deficits due to either cord or the spinal root injuries, or maybe plexus injuries, or other systemic features, for example, neurogenic shock that may complicate spinal cord injury. So what are the signs that can occur due to primary impact? They may be either direct or indirect. Now, is a patient fallen at workplace onto a brick? Okay. So you can imagine someone landing on the back and the back landing on a pointed place. Obviously, someone is trying to develop hyperextension injury. And you can see the extent of hyperextension injury. Right? This mechanism, what exactly happened in the history, is really important in assessing spinal injuries. Now, something like this will be obvious, but sometimes you get subtle changes like small compression fractures or some grade 1 or mild listhesis. Sometimes you are not really sure whether these radiological findings are acute or that was there for a long period due to degenerative spine disease or other pathologies like osteoporosis. So in such a situation, always go to the history and ask the mechanism, what happened. Then you can see whether the mechanism of injury is compatible with your radiological findings. If they are compatible, you need to think with a higher suspicion that what the subtle changes you see in your radiological imaging are likely acute. But if they are not compatible, the subtle changes you see in an X-ray or a CT, especially X-ray, the CTs and MRIs will be more conclusive, but may not be always available. So subtle changes in an X-ray, if it is not compatible with the mechanism, then probably that what you see is an old finding. Now this is the vice versa. Again, at the working place, while making a slab, a concrete mixture machine that was on the slab fallen onto the abdomen of the patient with abdominal contusion, you can see hyperflexion injury. Similarly, a forehead contusion in an old lady or old man coming with a fall may indicate central cord syndrome due to hyperextension of the cervical spine injury. Penetrating injuries to the back, obvious, no explanation is needed. But sometimes indirect things like gunshot to injury over the abdomen, you can see the reflective effect of the bullet and you can even see the artifact from the metal piece causing shattered vertebral body. So it is important to look these signs, not only because always we tend to concentrate on this part, neurological deficit, but not only that, others may be also important in certain situations. So what are the signs that can occur due to vertebral and bony ligamentous injury with or without associated soft tissue injury? If there's a fracture in a conscious patient, you may feel tenderness over the fractured site. There may be a boggy hematoma over fractured site. And if there's a spondylolisthesis, a vertebra has slipped over another one, you will see a step due to the listhesis, or else something like this, what I showed earlier, may cause acute deformity of the spine. So then signs due to the neurological deficits, this is our primary interest most of the time, though we cannot underestimate the other ones, as I told you. Due to the neurological injury, patient might complain either radicular or neuropathic pain, depend on what is involved. And patient might have varying degrees of sensory deficits, maybe tactile sensation, maybe pain and temperature sensation, maybe proprioception, depending on the particular injury. These different sensory modalities can be impaired to a varying degree. Motor deficits, either upper or lower motor signs, and sphincter deficits, either bladder or bowel or both, and also the sexual dysfunction. But usually it is not a concern in an acute setup, but these will be more important or more practical in an acute setup. So these signs, so the neurological deficits, they primarily depend on the level of injury. We know our spine starts at the craniovertebral junction at the skull base, and the vertebral column goes up to the coccyx. And in an adult, the spinal cord extends up to the lower border of L1 or the first lumbar vertebra. Below that, you get nerve roots of the quadrate equina. So we know our spine can be injured from C1 to right up to the coccyx. So which level this injury has happened and the extent of injury? Is it a complete cutoff of the spinal cord or only one side or the anterior side, posterior side? How bad or how severe the injury is? And whether the patient is in spinal shock or not. I thought it's easy to discuss this in the reverse way. So I'll continue the discussion on the reverse direction. So when you talk about the spinal shock, what is spinal shock? Can anyone tell us what is spinal shock? You all need to keep awake, so please talk, and that will help all of us. So what is the definition of spinal shock? I'm pretty sure you all have heard about it. Anyone? Okay. Spinal shock is temporary cessation of all the functions of the spinal cord below the level of injury, from which patient may recover to a variable degree over a variable period of time. By definition, it is temporary. It's temporary. And remember, it's all the functions of the spinal cord. Not only sensory, not only motor, not only sphincter. All the functions will be gone below the level of injury. And recovery is variable. It varies from patient to patient. What percentage will recover? What percent, how long it will take? It's all variable. And it will depend on how much will recover, what percentage will recover, will depend on several factors which will be discussing under prognostic factors. Right. However, the cessation of all the functions, this may complicate or this may make a confusion whether this is a partial cord injury with spinal shock or whether this is a complete cord injury. Sometimes in the subacute stage, you may see the patient. It may be very hard to differentiate these two. But if the clinical and radiological findings are favors incomplete injury, for example, you may get a clinical scenario where there is evidence of some purposeful and voluntary movements of the limbs after injury or some sensation after injury, but now it's completely gone by the time you assess. It may be jolly well in partial injury has become a complete injury due to improper handling. Up to 1/4 of the spinal injuries happen after the initial impact during the transport and initial handling. So it may be the improper handling would have converted a partial injury to a complete injury, or else it may be partial injury with partial injury with spinal shock. So if the clinical and radiological findings favor is incomplete injury, you might have to treat and see, and only time might give answer. And when we talk about the extent of the injury, it can be either complete or incomplete or as partial injury. Complete injury is complete loss of function at the level and below the spinal injury. But in a subacute space where there is secondary cord injury and cord edema, the clinical level may be higher than actual injury. For example, someone may present with cord contusion at the level of D6 or 6th thoracic vertebra, but in the subacute phase, the edema may extend up to 3rd or 4th thoracic vertebra. And when you do the clinical assessment, the clinical deficit may be at the level of 3rd or 4th thoracic vertebra. Right? Then partial or incomplete cord injury will have a variable clinical pictures at the level of injury and below depending on the extent. Now you can see this is an obvious complete injury. Not expect nothing more to expect. You can see a complete injury and hardly anything else to expect. Right? But occasionally you may get different scenarios. So that's the importance of investigation and proper management, which my colleague will discuss, and I'm not going to discuss. Now, this is one of the luckiest patient I have met in my career. You can see grade 3 or total dislocation of the C3 over C4 vertebra. But if you look at the MRI, the cord is intact because he was lucky enough to fracture his lamina same time when he was dislocating the vertebra. So it was like decompressive laminectomy. So that because of that fractured lamina, his cord was saved with minimal neurological deficits. So as we said, the neurological signs depend on the level of spinal injury. So higher cervical spinal cord injury. If there's a severe injury above the level of third cervical vertebra, the expected clinical sign is nothing but the death. Why? Can anyone tell why it is the scenario? With your basic knowledge in anatomy? We know respiration is maintained by intercostal muscles and the diaphragm. So intercostal muscles has segmental innervation via the intercostal nerves in the thoracic from the thoracic spine, and the diaphragm is supplied by the what nerve? Phrenic nerve. So what are the root values of the phrenic nerve? C3, C4, and C5. So if there is a severe injury above C3 or the third cervical vertebra, both phrenic nerves and the intercostal nerves will be gone. So there will be nothing other than the respiratory arrest and the death. Incomplete injury, it may be different. I'm talking about complete injury. Right? But if the injury involves the lower cervical spine, then the patient can have paradoxical breathing. What do we mean by paradoxical breathing? What's the meaning of paradoxical breathing? When we say paradox, it's going in the opposite way than the anticipated way. Now, for example, when a healthy person breathes in during the inspiration, the chest wall will expand because of the intercostal muscles. And because the diaphragm moves down, abdomen will also be expand. That's the normal scenario. Similarly, during the expiration, due to the elastic recoil of the lung, the chest wall will goes in, and because of the diaphragm relaxes and moves up, the abdomen will also goes in. So that is the usual finding. So paradoxical means now these happening in the opposite way. Now we know if there is severe injury involved in the lower cervical spine, hopefully the phrenic nerve is intact, so the diaphragm is moving. But the intercostals are gone. Intercostal nerves are not functioning, so intercostal muscles are not innervated. So during the inspiration, diaphragm will move down so that the abdomen will be distending or enlarging or coming out. But the chest wall, because now it has become a passive paralyzed wall, the chest wall will be going in during inspiration. The disadvantage is that will further compromise. So that will further waste the effect of the diaphragmatic movement. Similarly, during the expiration, diaphragm will relax and goes up. So abdomen will be going in, but chest wall is passive. So chest wall will be kind of expanding or coming out. So again, diaphragmatic movements will be wasted. So that is paradoxical breathing. Because of that, they are at high risk of respiratory compromise and respiratory exhaustion. They can get exhausted themselves just by breathing. Then we know our upper limb innervation is from C4 or C5 to T1. So they will have lower motor defects in the upper limbs and upper motor deficits in the lower limbs. And they will have sensory deficits below the injury, either tactile, pain, temperature, proprioception, or depending on the extent, the tracts involved. And they can have sphincter deficits and they can have neurogenic shock. What is neurogenic shock? What do you mean by neurogenic shock? Is basic physiology. We all know there are two sympathetic chains on either side of the spine, which gets input from the spinal cord. And this sympathetic chain innervates all the blood vessels in almost all the blood vessels in the body to maintain a vascular tone. So when the input from the spinal cord to sympathetic chain is impaired and subsequently sympathetic tone on the blood vessels is gone, there will be passive dilatation of the blood vessels, causing pooling of blood in the vessels without normal vasomotor tone. So that will cause distributive shock. Although the blood volume is normal, assuming there is no hidden or concealed bleeding in the abdomen or pelvis, which may be hidden without physical signs due to spinal injury. Even the blood volume is normal because because the vasomotor tone is gone, they can go into neurogenic shock. So thoracic spine, hopefully the upper limbs will be spared, but they can have upper motor deficits in the lower limbs, sensory deficits below injury, sphincter deficits, and neurogenic shock will happen usually if the lesion is above the sixth thoracic vertebral segment. Lumbar spine, because usually the spinal cord ends by the lower end of L1 in adults, usually what will happen is they will have lower motor deficits in the limbs, sensory deficits below the injury, and sphincter deficits. So it is very important to document all these clinical findings in an objective manner for the management, especially for the monitoring. So we know what happens over the time. So one of the most widely used is American Spinal Injury Association or ASIA impairment scale, which is from grade A to grade E. Grade E is the best where you get normal motor and sensory function. A is complete loss of everything. So B, C, and D is in between. B is in. So all these include incomplete injury. So grade ASIA B is preserved sensory function, but complete loss of motor function. C is preserved motor function, but less useful. D is preserved motor function with fairly good function. And there's a well-known Asia chart that can be very useful in documenting your findings and monitoring. Although you have forgotten the dermatomes and root values, this Asia chart has all these details. So it's very easy to document and see what happens over the period of time. Not always, I repeat you, not always, but sometimes the incomplete injury to the spinal cord may result in classical clinical pictures, so what we call as syndromes in some patients that I mentioned right at the beginning. So I will go through the common ones of clinical interest. The central cord syndrome. This is the most common type of incomplete spinal cord injury. Usually, this happens due to hyperextension of the neck, leading to compression of the central part of the cervical spinal cord. And the hallmark feature is weakness affecting the upper limbs more than the lower limbs. Weakness affecting the upper limbs more than the lower limbs. Can anyone tell me why? Why this funny scenario? Now, this MRI scan, you can see there's altered signal change, a white color indicating edema in the central part of the spinal cord. And if you look carefully, you can see there's a disc bulge which is likely to have been there for a long time. So this central cord injury is fairly common in older people where there's already existing degenerative cord compression. Because when there's a cord compression like that, during a minor, even minor acceleration, deceleration injury, or during minor stretch on the spinal cord, the segment above can move, segment below can move, but this segment cannot be moved. So it forms a junction between a relatively mobile and immobile segment, so causing injury. And if you see the cross section, of the corticospinal tracts, those of the cervical segments lies most medially, whereas the fibers coming from the lower extremity of the body lies most lateral. So when the central part of the cord is injured, the nerve fibers coming from the upper extremity of the body, mainly the upper limbs, will be badly affected. So that is why they get upper limbs, upper limb deficits more than the lower limb deficits. And of course, there may be other sensory deficits depending on the extent of the injury. Then you get posterior cord syndrome when there is damage to the posterior column. Usually, this is not due to trauma, but things like epidural abscesses commonly. So we all know the dorsal column transmit the sensation of tactile sensation, proprioception, and vibration sense. So damage will cause in loss of these sensations. Loss of proprioception or the joint position sense, loss of vibratory sense, and loss of tactile sensation. But because spinothalamic and corticospinal tracts are unaffected, usually these pain, temperature sensations, and motor functions will be preserved. In the anterior cord syndrome, the anterior part of the spinal cord will be gone. The commonest cause is usually again the damage to the anterior spinal artery. So usually our corticospinal tracts are here, lateral spinothalamic tracts are here. So usually the lateral spinothalamic tracts and the corticospinal tracts will be affected. So because the lateral and anterior spinothalamic tracts are gone, they will have loss of pain and temperature sensation bilaterally. Because the corticospinal tracts are gone, they will have motor deficits below the injury. And because the dorsal columns are unaffected, tactile sensation, joint position sense, and vibratory sense will remain intact. And Brown-Sequard syndrome is another interesting syndrome. This usually happens because of the hemisection, either right side or the left side, hemisection of the spinal cord. When one side is gone, we know in that side, the anterior and posterior spinothalamic tracts will be gone. The corticospinal tracts will be gone, and the posterior column will be gone. If you can remember your basic neuroanatomy about sensory and motor decassation, we know pain and temperature sense. It crosses to the opposite side within 1 or 2 spinal segments. So when half is damaged, there will be loss of pain and temperature on the contralateral side, couple of segments below. And the motor decassation happens fairly high up. Because of that, patient will have motor deficits at the same site, ipsilateral site. And because the pain and temperature sensation takes couple of segments to cross over to the other side, couple of segments, so that at the level of injury, the patient will have loss of pain and temperature at the same site. And also, because of the impairment of the dorsal column, patient will have loss of tactile sensation, joint position sense, and vibratory sense at the same site. So this is the same thing. Ipsilateral loss of motor function below the level of injury, loss of tactile sensation, proprioception, and vibration below the level of injury on the same side, and loss of pain and temperature on the other side, couple of segments below. Then there is something called conus medullaris syndrome. We all know the spinal cord ends as coda equina. The part just before the coda equina is called conus medullaris because of its shape. So this is a terminal part of the spinal cord, just proximal to the coda equina. So characteristically, they will, because this contains the sacral segments, it will be a loss of sacral nerve root functions. So Achilles tendon reflex will be absent or diminished, and there may be bladder and bowel impairment together with sexual dysfunction. The coda equina syndrome, that's the last part. So this is usually due to the compression of the sacral nerve roots, and it may be at the bladder or bowel involvement, reduced sensation in the sacral area, what we call as saddle anesthesia, and sexual dysfunction. And because this is the area where there are nerve roots, they tend to have a lot of leg pain or radicular pain and sensory and motor deficits related to those nerve roots. So this conus and the coda equina, they lie close to each other. So coda equina and conus medullaris syndrome, they may kind of overlap, and sometimes it may be hard to differentiate. But there are some classical differences, though it is not a universal rule, or you may not see always. For example, in conus medullaris syndrome, they tend to get mainly perianal sensory loss, whereas coda equina, they tend to get saddle anesthesia or sensory loss over the sacral area. And conus medullaris patients tend to have more prominent back pain, whereas because of the nerve root compression, the coda equina tend to have a more radicular pain. And also, conus medullaris tend to have both bladder and bowel impairment, Kodaikvaina, same thing might happen. I repeat, the same thing might happen, but generally they tend to involve the bladder more than the bowel. And usually this is sudden onset, and this may be gradual onset because there is space within the spinal canal due to root compression. So finally, what are the prognostic factors of the spinal cord injury? If you talk about prognosis of the spinal cord injury, the sad truth is this: overall prognosis is quite poor. It's very poor in severe spinal cord injury, right? Because less than 1% of patients with spinal cord injury will recover complete function by the time they were discharged from the hospital. Some other patients may improve further over the long period of time. They have not improved a lot by the time of discharge. Does not mean they are not going to improve over next few months. With proper management, they may improve, but the complete recovery chance is very low. And not only the deficits, they have a very significantly increased mortality in the first, especially in the first year of life. Even if they survive the first year of life, they are most of the time they are all survival or the life expectancy is tend to be shorter. Right? Even in the Western world, only 12% will go on to productive employment, and less than half will get married even in the Western world, and maybe probably a positive effect of the spinal cord injury. And when you think about the prognostic factors, these are the recognized prognostic factors. One thing is the initial American spinal injury or the Asia impairment grade. If the patient is of higher grade, that indicates the minimal deficits, their prognosis is better. But if they have lower grade or the disability is very high, very bad disability, the prognosis is poor. And the level of injury, obvious, higher level of injury, poor prognosis, lower injury, lower deficits, and better prognosis. And the severity of initial injury. If the initial injury or the primary cord injury is minor, likely outcome will be better. If the primary cord injury is severe, likely outcome will be poorer. And old age, higher the age, outcome tend to be poorer. And there are certain MRI signal characteristics like spinal cord edema, hemorrhage, they predict the worst functional outcome. You can see a patient, you can see this black spot, which indicate a hematoma, small bleed, and the edema area indicating the contusion. Right? So this indicates poor prognosis. And probably what we can correct as clinicians is this timing of surgical intervention. There are overwhelming evidences to support that early surgery within 24 hours, actually even within first 12 hours, early surgery improves the outcome a lot. So if there's a treatable patient, please don't keep waiting and waiting and waiting and then refer for neurosurgical intervention. Refer them early if the patient is worth to treat. There may be patients that kind of who will get minimal benefits of treatment, but surgical intervention. But if the surgery is indicated, it has to be performed as soon as possible. And I'm pretty sure Dr. Stansky will talk about it in detail. And this is what Dr. Charles Tater said in 1982. Final outcome of the spinal cord or the prognosis depend upon accuracy, adequacy, and speed of first stage management, diagnosis, and the treatment within first few hours. Right? We don't have Dr. Charles Tater here, but we have Dr. Stansky here to talk about. So I will stop my presentation here. Thank you.
Can everybody come to the front? Right, so what I'm going to speak about is mostly on surgical aspect. So you can talk me and ask me questions, right? He's working or asleep. Okay. Thank you. Ah, right. So now for me, it's going to be a difficult task after all the eminent speakers have, explained in detail spinal cord injury. Now, first we'll go and define what a spinal cord injury is. As you can see, it's on the screen. Why is it important for us to manage spinal cord injuries? And what is the basis? So now most of y'all will be general surgeons working in the peripheries. Some will be coming to the tertiary centers, but you will be mainly the first respondents when you get a head injury patient or a spinal cord injury patient. Now, as Sanjeev and my previous speakers stated, brain injury and spinal cord injury are in two parts, primary injury and secondary injury. Now, as surgeons, our aim is to prevent secondary injury. Primary injury, you can't do anything. It is prevention, mainly in road traffic accidents, preventing those. But as surgeons, your main aim and our main aim as neurosurgeons is to prevent the secondary spinal cord injury in this aspect or brain injury and to give the best possible situation for the spine or the brain to have a good outcome. So that is our duty. That is what we are expecting of you in regard to patient management. Okay. Now, these, I think Charit did state regarding the three-column spinal fractures, the concept. Now, initially, these concepts, initially it was described by Holsworth. This was in 1963. He described a two-column concept. Now, these concepts were initially put forward so that we could ascertain which patients have a better outcome and which patients need to be treated or intervened. So it will be easier for us to make a decision. So that is how these concepts came into being. So initially in 1963 was a Holsworth concept. And what did he say? So he had two columns, anterior and posterior. But later on, Dennis, this is what Dr. Charit Nanyakara did say, came to the third column, the three-column concept. So the anterior column, middle column, and posterior column. Now in this, if one column, say the anterior column only is compromised, then the patient, you can take it as stable and you can manage it conservatively. Whereas if two columns are compromised, then surgery or intervention is indicated. So that is why this column theory came into being, to help us to decide which patients need intervention. So as a general surgeon in the periphery, if you get a patient with anterior column only disruption, what would you do? You can manage it conservatively. You can get the opinion from the neurosurgeon, yes, and then can manage it conservatively. But if you see that there is more than two columns involved, then you have to think of the need of intervention, even if the neurology is intact. That is to prevent secondary injury from occurring. Okay, the patient will be fine. He has disruption of two columns. You try to walk or he does something, secondary injury will occur. And then he is quadriplegic or paraplegic or some neurology will occur. So our aim is to prevent those injuries from occurring. So, like I told you earlier, Dennis, back in 1983, gave this concept, and this is more or less what we deal with. Now, this was given to the word thoracic and lumbar region, but this is also more or less accepted in the cervical region from C3 downwards. C1 and C2, this cannot be applied because the anatomy is different. Charit did describe in detail regarding various classifications, right? Very complicated classifications from the AO section, right? So you don't have to memorize all those, but if you just have a concept of the three-column theory for C3 and downwards, you can make a decision on whether the patient needs to be intervened or not. Now, in the cervical region, when you get a MR, a CT, or an X-ray, you have to assess whether the patient has a stable spine or non-stable. So the ABCs of spinal X-rays. A for alignment. When you get an X-ray, X-rays are available everywhere. So this is what you will be dealing with. Some centers will have CTs, which is a better imaging modality. But in the ABCs and spinal X-rays, A alignments, you go for 4 lines. The anterior, posterior, base of the spinous processes, and tip of the spinous processes. With this, you can identify whether there is any disruption of the alignment. If there is any disruption, then you have to suspect some type of fracture, whether it be facet joint fracture or disruption of the disc. And then you have to go in for a more detailed investigation, such as CT, or if there is a neurology, MRI. So again, ABCs of X-rays. B is for bones, C is for cartilage, S is for soft tissue. I'll just run through this because of the time constraints. Okay, but you can read about this. These are mainly for you as the initial respondents of a patient after trauma, right? So when it comes to deciding whether the patient needs surgery or intervention or not, now you get various classifications. This is 1, right? Like it says, if the score is less than 3, you can treat it non-operatively. If it's 4, you can decide whether to do surgery. If it's more than 4, you do surgery. So a lot of classifications. Now this is what Charit said, showed. Now these in detailed classifications are good, but these were mainly incorporated for research purposes so that you can identify various types of fractures and categorize them. And it will be easier for people in various hospitals or various countries to ascertain which type of fractures have the best outcome or what type of treatment has the best outcome. So that is why you have a lot of classifications, which I mean, it's good. But the classifications taken in Sri Lanka, in America, in Europe, in India, all are different. So I would suggest knowing it, but don't take how do I put it? Don't go into detail in regarding the management in regarding these classifications. Just have an overall view in your aspect. It would be easier and more beneficial for you and the patient, right? So here again, the AO classification and subaxial classification system, right? So now, these in the previous one, we had the injuries of A, B, and C. And in these, they gave a concept of what the treatment should be. type A injuries, right? Type B injuries, type C injuries, right? So this is very high classification. So I won't go dwell into that. I'll just skip it. Now this, I think, someone has gone through it. Now, what does happen when a spinal injury occurs? Right? So in microscopic analysis, following the initial impact of the spinal cord, edema occurs. Why does edema occur? Because of coagulating factors and vasoactive amines, ionic imbalances, increase of release of excited neurotransmitters. Now, all these can, by the release, can cause secondary damage to the cord or even the brain. Now, this is after the impact. So, if we reduce the edema, free radicals, neurotransmitters of glutamate, the outcome would be better. Do you agree? Right. So, this is the one that is causing the damage as the secondary insult. So, if we prevent this from happening, the patient will have a better outcome. So, how do we do this? How do we reduce the free radicals, amines, neurotransmitter glutamate? So, there was research on what medication or what type of treatment would tend to reduce these types of chemicals, so to give a better outcome. So one was they used methylprednisolone. Now, the initial tests of methylprednisolone were done in mice, right? They found out it prevented the loss of spinal cord neurofilaments. It increases the impulse, improved blood flow, enhanced sodium potassium ATPase activity, and preserve the cord structure. So in theory, methylprednisolone was a good type of drug to be used in spinal cord injury. Has anybody used methylprednisolone in spinal cord injuries? Anybody? No? No. Why not? Theory is there, but theory is not everything. So theoretically, methylprednisolone should improve an outcome by preventing secondary spinal cord injury. So then what now that was done in mice, so they wanted to find out whether it would be effective in humans. So in 1990, the second national acute spinal cord injury study was done, and that showed administration of high-dose regimens of glucocorticoid steroid methylprednisolone had no significant differences in motor or sensory improvement, right? There were no significant differences or complications. But in going into, now in this instance, they didn't know when to give it. Some people were given methylprednisolone after 24 hours, after 8 hours, right? But when they went into detail on how the methylprednisolone was given, they found out that it showed improved neurological outcome. This is the, this is the last one, right? When it was administered within 8 hours of injury in a dose regime of this, some did have a good improvement. So that is why, that is when people started using methylprednisolone. This paper came out in 1990 and people started using it from 1993. But prior to that, they said there is no benefit of using it. But after this paper, only people started using it. Then what happened? So this was the recommendation before 8 hours. The placebo did poorly, whereas methylprednisolone group had a better outcome in some individuals. So they what gave a what do you call it? They told us that some people do improve with cervical what in spinal cord injury. So because spinal cord injury, most of the people did not recover. They were trying to find out something that would help them. So most people were trying to find something that would help. So that's why they started giving methylprednisolone. So from 1993, people were giving methylprednisolone. Then this paper came out in 2013. This was done by a neurosurgeon in America. Now he had a study and found, and his conclusion was, right, there is no evidence that steroids will have a good outcome. In fact, he said the complications and deaths with people using methylprednisolone is much more. So this was a landmark study in 2013. So this was published in America. After this study, everybody stopped using methylprednisolone because this was a widely publicized study. Insurance companies started suing the doctors if they used methylprednisolone in America. That's why they stopped. They didn't want to be financially burdened by all the litigation. So that after that, in America, they don't give methylprednisolone. But what was was it actually correct or not? We don't know. So then in 2017, there was a paper where they did a meta-analysis of all patients who had methylprednisolone. And what the conclusion that they found was that, using the initial dose of methylprednisolone given before 8 hours of the incident did improve in some patients. But the patients that had lot of complications were the elderly who had a lot of comorbidities. As you know, if you get steroids, their blood sugar will skyrocket. It's very difficult to manage it. They will have a high infection rate. So when they went into a meta-analysis of younger patients, those patients did have an improved outcome, whereas the elderly did not. So the recommendation from that study, now this was a European study, was to do not offer 24-hour infusion to adult who presents after 8 hours. So the cutoff is 8 hours. So it's very short period of time. So you as the initial respondents to a trauma patient will have to decide whether you want to start it or not, depending on the patient. So we won't give you a blanket protocol on when in which patients should be started and which patients should be not started. So it will be dependent on the patient and the situation, right? So, but this is, I think Charit will tell us the new updates on methylprednisolone. So ideally, this is what I follow. If the patient comes within 8 hours, young patient, cervical injury, yes, I would give. But if it's more than 8 hours, elderly with a lot of comorbidities, we would not give. Right. So this is the dosage of the methylprednisolone. Okay. So next was the timing of surgery. Now, someone did tell that the timing of surgery done early does improve the outcome. Now, historically, therapy for spinal cord injury was close reduction, prolonged external immobilization in the bed. So you get an injury in the spine, the patient will be in the bed, strict bed rest, 3 months, right? And then after 3 months, you start to mobilize the patient. But as time went on, found out that intervening early would give a 35% better outcome in patients. So most studies considered early surgery as 24 hours and late as more than 24 hours. Why 24 hours? Why not 8 hours? Why not 12 hours? So 24 hours was taken because of logistics. So when a patient comes, I mean, it's very difficult to do it immediately. So within 24 hours, you can get the theater ready, get all the implants ready, and roll him into theater. So because of logistics only, that they took 24 hours as the minimum. So it has actually nothing to do with the physiology. It's just for logistics. Right. So has anybody seen this? Everybody? No? What is this? No? What is it? It's a skull caliper. When do we use a skull caliper? Nobody has seen a skull caliper. You have seen. So when do we use a skull caliper? Have you seen it being used? Where? Sorry? Yeah, dislocations. So what do? You put the skull caliper on and then you put a weight. So in cervical injuries, this was the norm. How long should the patient be on bed rest? One day, 2 days, 2 months, 3 months? Earlier when we were registrars, I can remember when going into the accident service, orthopedic ward, you see patients like this waiting in the bed for 2 months, 3 months. They can't have a bath, they can't turn around, right? So we do still use calipers, but that is in the acute event to try to reduce the fracture, not as a mode of treatment, right? Long-term treatment. So you can see a patient like this. Would anybody would like to be like this in the bed for 3 months? No. Yes? Yes or no? No. So then what is the option? Right? Now, this is the paper in 2016, time of decompression in acute spinal cord injuries. The conclusion was, right, the early surgery did improve outcomes, but it was inconsistent. So still the consistency is not there, but as surgeons, we take anecdotal patients and patients who we do early. Why do we want to actually do surgery early? What is the main reason? So even if the outcomes are not beneficial, why would we want to do surgery early? What is the main reason? So it's not because of outcomes or in outcomes in the sense of neurological outcomes. So then why do we want to do surgery early? Okay, I'll put it this way. If you don't do surgery, what will happen? Where will the patient be? Sorry? Can't hear. So if you come with a cervical fracture, which is unstable, you manage it conservatively, right? Where would you be? Would you be at home? In the hospital in a bed? Would you be able to be mobilized? Yes or no? No, you won't be able to be mobilized. So one of the main reasons that we do early surgery is because we can mobilize the patient early. You get reduced amount of bed sores, reduced amount of secondary infections such as pneumonia, right? So the main reason that we do early surgery so that we can mobilize the patient. And in addition, if they get a good outcome in neurology, well, good, right? Right. So taking into consideration now, this patient is a 34-year-old who came after accident, complained of neck pain, no neurology. This is the X-ray. Do you see any abnormalities? So you are a surgeon in, say, the, say, how do you say, as home agam. Patient comes like this, only complaining of neck pain. Otherwise, everything is okay. This acceptable? Enough? You say it's okay? You can go home? Why? Sorry? Yes. There's only where? 2, 3, 4, 5. That's all. So he's having neck pain after. What do you have to do then? What is the best mode of imaging? CT. Okay. So this was the CT of that same patient. Dislocation. Right? So he's neurologically intact. Nothing wrong with him. Only complaining of pain. What are you going to do? Conservative management. What? You're going to fix it. Yeah. So this is after fixation. These were done, I mean, in Kurnagal, when I was in Kurnagal. So we didn't have MRIs at that time. So these are the CTs. So we have done a small laminectomy and we have put uh, screws to, uh, what is it? Lateral mass screws to C7 and pedicle screws to T1. So main thing is after surgery, you can mobilize, he goes home. Easy. What happens if you don't fix it and you send him home with a collar? He will come back with a quadriplegia, quadriparesis, young patients. Next patient. Again, has come with neck pain, neurology normal. Anything abnormal that you can see other than a straight spine. Still, like the previous one, it's inadequate. So most of the time, the X-rays, you can't make a consented decision of whether the patient has a fracture or not. Like I told you, if you have any suspicion, get a CT. It doesn't matter. Go get the patient to the nearest place where you have a CT, get it done. You exclude it, you're fine. So what has happened here? There's a fracture and it's going backwards, compressing on the cord anteriorly. For this, what would we do? Now, olden days, we would do, olden days means quite recently also. We put the skull caliper and keep them on the bed for 3 months. This one how do we fix it? So now I'm trying to tell you different ways of what we do in fixation. So it's a burst fracture, it's the vertebrae, the body is totally gone. It's causing compression on the spinal cord. We have to take this out. How do we can we take only this part out? No, we can't take only this part. So we take the whole part of the corpus. We call it corpus. And this is what we did. This is a expandable cage. We have taken that vertebrae out, fixed it, and now no compression, he is fine. So most of these patients, once you do it, second or third day, they go home. Now this you should be able to identify. Again, patient came. All these patients have a normal neurology. Is there anything abnormal that you can see on the X-ray? In this X-ray, you can see the abnormality. What is the abnormality? Anybody? Don't worry, you're here to learn, right? You can make mistakes. Main thing is to make mistakes here, not make mistakes when you are a consultant. Any abnormality that you can see? Yeah. C2. There's a malalignment. Now, when you take an X-ray, what are the 4 lines to see the alignment? Anterior. Is the alignment correct? No. So then you have to think of something happening here. You can see this alignment is also not correct. Though the spinous processes look okay, it's the vertebral column that is malaligned. So you get a CT. In the CT, you can see both facets of C1, C2 are fractured. So what would you do then? Again, skull caliper? No. In this, since the facets here, I mean here only the tip had gone, so this area was available to put the screw, and even in this, we put the screw into the body. Because the beauty of the C2, it has a very big pars or pedicle. That is the biggest, so you don't, it's much bigger than all the other C3s, all the other cervicals, right? So it's very easy to put a screw in. So we put a screw in here and here, and put a lateral mass screw on C3. Right? So there's a little bit of malalignment, but it is fine, it's stable. Okay. Now he of course had a neurology, and this is the sorry. So now this patient had a dense fracture, type 2. Now you know the types, type 1, type 2, type 3. Type 1 and type 2 can be managed conservatively. Type 2 will have to be managed with intervention. In addition, he had a C3 facet joint fracture on the right side. Now, if it was a single facet joint of C3, we could have managed it conservatively with a Philadelphia collar. But in this aspect, he has got a C2 fracture also. So if you take a C2 fracture, type 2, you think it is unstable. What are the types of intervention or methods of managing it? You know, C2 fractures. How do you manage it? One is this. It's called a halo vest. You have a vest, putting fixing the head onto this so that the head cannot move this like this. And you keep it for how many? How many weeks? Yeah, 6 weeks to 3 months. Sometimes you don't know. But mainly, this is mainly for, say, some people put it for type 2 fractures also, but I don't know how good it. Would you like to be like this for 2 to 3 months? 3 months like this, you can't do anything. Right. Okay, good. Nobody likes to do it. So always think of what the patient should go through when you're thinking of the type of management. So the other way of managing is putting a leg screw, right? But to put a leg screw, you have to have MRI, see whether the ligament is intact, because otherwise when you put the screw, the fractured particle will be pushed back and cause a compression of the cervical cord. So you put a leg screw. This is the best form of treatment for a C2 dense fracture because it keeps the anatomy intact. But this is quite difficult. I don't know. I have tried it. I was not successful. For this, you have to ideally have two C-arms. One C-arm going in the AP position, one going on the lateral position. Then you can identify exactly where you are putting your guide wire through. Otherwise, if you have one C-arm, it can't be rotated AP and lateral. It's very difficult. So we tried. Personally, I tried only 2 or 3 times, but not successful. I don't know about yours. So I gave up the idea of putting a leg screw, and the leg screws are also not available. It is available in Anuradhapura, but not really available. So next one is this. What is this? Some people do this for C2 fracture. This is called a craniovertebral fixation. So you fix the cranium to the cervical spine. So it will be something similar like this, but in a more permanent way. If you do this, the patient will be like this. Can't flex, can't rotate, and they will be it is quite painful even after surgery. This is mainly used if there's a dislocation between the cranium and the vertebrae, like Charit did say. So for some C2 fractures also, some people use it, but I would avoid it. So then what do? So this is what it will look like on a X-ray. So what did we do for that patient? C2 fracture. What is the other option? Leg screw, this. We fixed it. We did a C2, C1 and C2 fixation. Now, if it was only the dents, we would have only put it to these two. Since there was a fracture of the facet joint, we put it to C4 also. Now, this alone will keep the C1 and C2 in one anatomical plane. So you will not lose your up and down movement, but there will be some limitation of your lateral movement. This is more, it is much better, easier for the patient, my opinion, I don't know about others, if there's a C2 fracture, to do a C1, C2 fixation. Right. Then timing of anticoagulant, do we have time? Anticoagulant therapy. So it can be given 72 hours. It is safe after traumatic brain spinal cord injury, even if it's what conservatively managed, and it's safe after 72 hours, 48 to 72 hours after surgery. Right? And enoxaparin, deltaparin. Rehabilitation. Now, rehab is the main reason that we do surgery early, so that the patient can be mobilized and sent for rehab. If the patient has not been intervened surgically and he has unstable fractured spine, or he can't be mobilized, he's bedbound, and then DVT, infections, all set in. So that is why we want to mobilize him early by, uh, stabilizing the spine. So these are papers in regarding to rehab of spinal cord injuries. I'll stop at that. Do you have any questions? Now, lumbar and thoracic also similar, right? The anterior anterior fixation, posterior fixation, you can go, right? I've just taken a snapshot of the cervical since any questions?
Right. So we'll quickly go to your queries clarification and so we'll quickly go through since we are coming to the latter part of the program today. No, what are you calling around? On full screen. So now since all our experts are here, so you can clarify. So especially when it comes to the head injury and spinal cord injuries, these are practical problems. So application of all the I said that all the head injuries are associated 3%, 10% chance of having cervical spinal injury. So when there's an unconscious patient, so you have treated him as having a cervical spinal cord injury. So Stravinsky, discussion to Stravinsky, what do you call this triple immobilization and how do you prepare the patient for stabilization at the site, on-site stabilization?
So triple, we call it triple immobilization. So triple means three. So it will consist of the cervical column, most likely a Philadelphia column. Then the two sandbags on either side, on a spinal board, and taping the patient to the spinal board. So in this way, the patient is movable on a spinal board without compromising the stability of the spine, especially the cervical spine, right? So ideally, that is the scenario. But unfortunately, in Sri Lanka, what happens when you meet with accident? What is the ambulance that you take? The three-wheeler. You are bundled into the three-wheeler, දෙකට නවලා ඔක්කොම මේව කරලා එහෙම තමයි ඉස්පිරිතාලට අරන් යන්නේ. So that should not be the case. You have to wait. Ideally, you have to wait for the ambulance. The thing is, our ambulances also, all, they don't have a spinal cord.
I don't think.
What is it? Yeah. 199. Some ambulances don't have oxygen either. So ideally, get the patient, you'll have to have at least 6 people mobilizing him onto the spinal board, then strapping him with the collar with the two sandbags on either side and tape it. And then only transport.
Right. So now that is a triple immobilization ideal way. So, right. So then you need to have a cervical collar on. So there are various cervical collars that we see. Right. So this is the collar. So what is the function of this collar and how to put it and how to use this one. To you, sorry. Yeah.
Okay, so it's a Philadelphia collar. The collar, the basis of the collar is that the patient won't have any movement like this or lateral. They'll be stable. So it should be applied in the shown way. So hard collars, soft collars are not, they don't stabilize the spine. So you have a chin, what we call the depression for the chin to be placed in, and you have to have the exact size. A collar that is too small or too big will not give you the desired effect. So it should be applied in the way. And these are much better collars, but what we have is the one on the right.
These two are the correct ones.
Otherwise, sometimes you can that the posterior part. Yeah, they put it
To the upside down. So
you
it's not
put it
marked.
the skull.
Yeah.
Some people. Yeah, it has to come down to the thorax.
Yes, so like the cervicothoracic junction from behind. So yeah. So and again, most of the time these are the collars that we have in our wards. The incorrect collar, right?
That you will limit till you can break your lateral movement.
Not rotatory movement is not supported, and again chin is not supported. So it's unsafe. But for your safety, if you can say, okay, we have applied the collar by putting this one, but this is useless. Try not to use that. And this is the other thing. Right thing in the wrong place. Right? I don't know what purpose. Right. Should not do that. We have many times we have seen this on the ward, right? And during the ward, the collar is like this. And next one, the log rolling. Saman. So can you explain the techniques of doing the log rolling and how many people needs to get involved and what is the function of responsibility of each of the member of the team?
Yeah, now this log rolling is a really important technique, right? Because one important principle in managing spine injured patient is you move the entire spine together. Right? One very bad thing you can do is to, like I told you in my presentation also, to create a junction between a mobile and a immobile segment. So that junction is always vulnerable for injury. So even the previous rights that the doctor described, now when you are stabbing, you have to stab the forehead as well as the body. Now if the cervical spine is injured, to stab only the forehead, patient will keep on struggling with the trunk and the limbs. And there will be mobile and immobile junction in the cervical spine, making cervical injury worse. So it should be avoided. So the same principle applies to the log rolling also. When we are log rolling, the entire idea is you turn the patient like a log. So minimally there should be 4 or 5 people. Right? So the one person should hold the head and the neck together. So idea is to straddle the shoulders using the thumb and the palm and support the neck and the head on either side of your hands and control the head, neck and shoulders as a single segment. Then there should be another second person to support the turning the shoulders and the chest. There should be another one to support the pelvis. And then the fourth one is preferably should be there to turn the lower limbs. So the entire patient is just turned like a log. So there should be enough humans of the manpower. Enough people should be around. And always the command should come from the person who is holding the head and neck. Because he is the one primarily stabbing the head and the cervical spine. So according to the person's command, so usually what we do is, say, okay, first come 1, 2, 3. Upon counting to 3, you turn the patient to about 90 degrees. So if necessary, one person after turning, the fifth person can go behind, go posteriorly, and inspect the back of the patient as a part of exposure and can feel along the spine to see whether there are any tender points in the conscious patient or whether there are any body hematomas or step due to a spondylolisthesis. You can feel that. And then if you want to transfer the patient to say from a trolley to a bed or a bed to a trolley to proceed with a CT scan or MRI, then you can turn the patient by 90 degrees and then you can keep a spinal board like that from a side. Then you roll the patient back onto the spinal board. You don't lift and keep the patient on the spinal board. You turn the patient by 90 degrees, you keep the spinal board, and then you turn the patient onto the spinal board. Then after that, you can make minor adjustment without undue movement of the spine. So again, once you take into the spinal board, it's always preferable to strap the patient. Because like when you are taking the patient to the spinal board, the patient might struggle, patient might get afraid. So always strap the head as well as the trunk. Don't strap only one. Then it will be quite bad for the cervical spine. And also, when you are log rolling, tell the patient, please don't try to help us. Because when you are when you try to roll the patient, if the patient try to do something different, that's going to be a disaster. So clearly tell the patient, please don't try to help us. We will do it for you. So relax and then once we give that permission to the patient, do it properly. Right?
Right. So need of a 4 or 5 people is a must. So in other countries, we all have experience. They never turn a patient without 4 or 5 people. But here what happened is one person, nurse is there to call the expert bystander and hold somewhere and turn the patient. Right. It's utter bizarre. Right. So we have to be very, very careful doing this maneuver. You have to
Even
practice.
if-
You have to practice this.
Even in the site of the injury, say someone has fallen down somewhere, if you don't have enough manpower in the field, you may not have a spinal board or what you have maybe a flat wooden board like a landline where you have to take the patient. Unless there is an immediate threat like a fire or a electric wire lying next to the patient, don't try to lift the patient without adequate manpower. Lift the person as he or she is at the fallen place, unless there's immediate threat. Get enough manpower, get a suitable board, and then turn the patient onto board.
Right. So next to move into the next one. So someone, these are other type of various the braces that we can use for the various places. So any idea what are these and what does the each functions roughly?
Yeah, there are various types of braces commercially prepared and designing for various purposes. So this will be decided by the neurosurgeon attending to the patient, but for you to be familiar with the basics, the one on the left upper corner is a lumbar corset. So that will primarily support the lumbar spine. So if there's any minor spinal injury involved in the lumbar spine, you can use that. Sometimes we use it for in the short term, not as a long term. We use short term for the degenerative lumbar pain also when they are severe pain. But in trauma, you can use it for minor injuries involved in the lumbar spine. The second one is kind of a halo type of a stabilizer that will stabilize the cervical spine. Again, the lower part will support the chest and the upper part is encircling the head, and the bars joining that will stabilize the cervical spine. Right. The third one is a thoracolumbar corset. So that will hopefully immobilize the thoracic spine as well as the lumbar spine. So if there's an injury involved in the thoracolumbar junction or lower thoracic spine, you can use that thoracolumbar junction. And there's the fourth one, I think, sorry, with regard to the third one, there's a special type, what we call as hyperextension brace. So when there's a hyperflexion injury, to prevent that, we give the patient a little bit of hyperextended position. yeah, you will get a large spinal bar in front. Finally, another cervical brace to immobilize the cervical spine. Again, you can see there's a, yeah, uh, there's a
Chin
part to support the chin as well as part straddling the shoulder and the chest. So the entire idea is you prevent flexion extension, lateral movement, and the rotation. All three movements are prevented.
It's for the cervicothoracic junction, basically.
Yeah.
Okay, so any questions of this? Good. Right, next, before I go into, I will go into the steroids with, so, Charit, so can you explain now, again, we have talked about this steroid, use of steroids in head injury and spinal injury. So what is the use of steroid, any indications, contraindications, any evidence? I think Stravinsky went through this for some extent. And anything you want to add? With
Yes,
evidence?
I agree with what was stated. So that's pretty much so. NASIX 1, 2, and 3. Those studies show that initially, I mean, I'm just pretty much reiterating what was mentioned. So it was initially people thought no, there is no place at all, and then eventually there was, this selective lot that benefited, and then NASIX 3, they realized that okay, the closer the treatment to the injury, we'll say less than 3 hours, the better the benefit. So like that. So is there a place? Yes, definitely if we get the patient early, but then in our setup, whether our patients do present on time could be a problem, which was actually mentioned. So if that is not the case, yes, we can use in that selected lot in spinal cord injury. However, now as I think Dr. Sanjeev Garusing mentioned in his presentation about the CRASH 1 trial. So CRASH 2 and CRASH 3, we have something positive, meaning tranexamic can be used. But CRASH 1 is for steroids, right? So, but in head injury, but we can't use based on that. It increases the mortality. Initially, people thought it will reduce the mortality by 15%. But then after the study, they realized no, it increases the mortality by 18%. So because of that, generally speaking, no. But then as per, what we discussed on the spinal cord, these NASIX trials, people are now again trying to find, okay, is there a small cohort that will actually benefit, because those crash trials were done some time back, and then like the NASIX one, it's too broad to sort of finalize and figure out, is there a small population that will benefit? So people are working on that. And then about the cytotoxic edema and the vasogenic edema. So cytotoxic edema generally does not respond to steroids, but then this vasogenic edema, it does. So then there is this two-phase in cerebral edema that, so based on that, some people actually think this, it's not well supported with evidence yet, but then later, as in not initial, during the initial phase of the injury, but later, if the patient still continues to have cerebral edema, if it is due to vasogenic edema, then just like steroids used in we say tumors, which responds well, some people say that there is a place, but trials are still undergoing for that. So basically speaking, head injury, generally speaking, no. Spinal cord injury, early presentation, yes.
Right. So what he means is steroid head injury. Actually, there are no indications, and it's contraindicated actually in head injury. Spinal injury, there is a place, but still we don't have the level 1 evidence for none of these. So it's basically level 3 or level 2.
I'd like to make a comment now. When you think about steroids, now what is the action of the steroids? One is to reduce the inflammation. And the other one it does in the brain is it stabilizes the brain, blood-brain barrier, right? So in trauma, the blood-brain barrier is disrupted. So then the indication for use steroids is not there. So in like what Charit said, vasogenic edema in tumors, even sometimes in abscesses, it stabilizes the blood-brain barrier. So then there is no free movement of water across it. So that's why the edema reduces when you use steroids. You have to know the action of the steroid. So theoretically, there is no indication in trauma. So they are trying to find out. But the only thing is to reduce the inflammation. That's all.
How much we say this, there's no indication for steroid, but still in the periphery, they said we have given a dose of steroids and we are sending the patient. Rather, we are increasing the risk or complications of steroids. So no point.
Actually, even the research is ongoing regarding the subacute and the chronic phase. not regarding the acute head injury. Acute head injury is clearly contraindicated unless there's a concomitant spinal injury.
Okay, the next question is the hypersmaller therapy. I think this should be thrown into Sanjeev. So he's not here. So I think I have to take that question. So hypersmaller therapy, sorry, osmotic therapy. So two osmotic the substances are there we have. So what are these? Mannitol and 3% saline available. So what are the indications? So most of the time when they refer a patient to us from the peripheries, they ask whether to give the mannitol or not. So when you want to give a mannitol or 3% saline. So patient GCS 15. I mean, there's nothing. Patient may be having a following trauma. CT scan is done. Mild contusions. Do you want to give mannitol before transfer? So these are the indications. When you have a patient with head injury, there's a deterioration of, you detect the deterioration of Glasgow scale. So patient is deteriorating, that then you want to transfer this patient, you want to buy some time. Then there's indication, no place for hypersmaller therapy. Then the focal neurological signs developing. So patient has been all right. When we are monitoring the patient, people start getting dilated, right? Or the Cushing's reflex appearing, right? Sometimes patients start fits, right? So, and again, if you do the CT scan show impending coning, right? And severe edema. So all these hypersmaller therapy is to buy time, right? So there is indication to give hypersmaller therapy by time. Why contraindication or contraindication? Sometimes I do not advise to give hypersmaller therapy when there's a bleed, just a bleed there. I will not say don't give mannitol. I will say don't give mannitol. Why? The tamponade effect is called in that blood clot. If you give the 3% saline or the mannitol, especially EDHs, then brain shrinks. Then it gives the take off the tamponade effect. Then the bleeding will be more. So therefore, there's a contraindication. So you have to be very careful when to use this mannitol. Any comment from that from the panel?
Yeah, actually, this hypersmaller therapy is more than 100 years old. More than 100 years old. But unfortunately, still we don't have any level 1 evidence. But definitely there are level 2 and level 3 and anecdotal evidence that it helps and saves life. But it is in general, as Dr. Nirukshan said, it's to buy time. Either you want to transfer the patient or theater is delayed because there's another patient being operated in the theater or something like that. Or either to buy time or when there's an established cerebral edema causing increase in intracranial pressure.
Right. So then two we have is mannitol and hypertonic saline. So again, I will rush through the mannitol. It's known for decades. We know about it. And again, it's an immediate plasma expander as well. So once you give mannitol, it grabs, it expands the fluid, it increases the cerebral perfusions for some time, right? So again, the other side effects of that is it increase the deformability of RBC. So RBC deform. So then easy perfusion. It enhances the brain perfusion. That's an advantage. And reduce and again mannitol effects maximum within 2 hours you can see the peak effect, but start effective within minutes. So high the efficacy. And then the mannitol is again as a free radical scavenger. It helps in you know that the trauma situations, the free radical formation is badly affect the spinal cord and the brain. So that's a chance. And bad side is it has a risk of renal failure. So those who are having renal issues, you can't use mannitol. And then mannitol itself has a rebound phenomenon. We also have the blood-brain barrier damage and vascular damage. So they can leak out into the parenchyma, and then the hypersmaller substance are within the interstitial space. So which eventually grab water into the interstitial space and cause edema more. So it's a bad side of it. And then hypertonic saline. Hypertonic saline again, it's again it's mobilized water across the intact blood-brain barrier. So its effects at the place where the blood-brain barrier is not the damaged brain, it's from the normal brain. And again, it enhances the intravascular compartment. It increases the cerebral perfusion. It's a good side of it. The plasma volume expansion. Again, it increases the microcirculation. And again, reduce leukocyte additions in traumatic brain. In the traumatic brain, there's an increased leukocyte addition, the microvascular thrombosis. So it prevents leukocyte additions. in hypersmolar therapy, I won't say no rebound phenomenon, but it's a very rare rebound phenomenon. And there's a risk of central pontine myelination when you're giving rapid transfusion of 3% saline. So mannitol and hypertonic both are equally effective at the end, but depending on the availability, you can use. And then sometimes the paper says the cerebral edema, which is resistant to mannitol, might will respond to hypertonic saline. Yeah. Any comments from the panel?
In regard to hypertonic saline, the issue with hypertonic saline is you have to have a close record of the patient's sodium levels. So when you give hypertonic saline, the ideal concentration that you want, plasma concentration, is round about 150. So there's no point giving hypertonic saline and just waiting. You have to reach that threshold. So you have to repeatedly look into the sodium levels. Whether that is possible in Sri Lanka, it's another thing.
Yeah.
That is the issue that we have. But like now in other countries, they give hypertonic saline, they always check the sodium concentration to get to that level. So the thing is, you can't give a high dose and get it right up, like Neuro said. So it's a little bit more time consuming and more costly also in regard to mannitol. Mannitol you can give and forget. So that is the guideline.
Yes, I agree with that. And in the meantime, I believe that now since we discussed about the possibility of using like the advantage of monitoring, in other countries they use even more than 3%. They have higher percentage. They have 7% in US. So and this is why I think the DECRA trial, which was mentioned earlier, that rather than going for a decompressive craniectomy, they infuse very high concentration of these hyposmolar solutions under monitoring, and then what they say is okay, that is as good as doing a decompression.
So from that, we conclude the program. Any question? Any questions from the audience? Very inactive audience. No question. Any question? Come on, you should have some. If you understood.
So now that means they know how to manage any brainstorm and problem.
So yeah, can you raise your hand? Did you get something? You learn from this picture? Raise your hand at least now. Have you learned something? Is it useful? Right, okay. So all our surgical registrars, right? Next time you will, years time you will become the consultant. Your surgeon also there, right? Okay. So I hope that's useful and you have learned something. And